Assalamu alaikum and good afternoon, everyone. I welcome you all again to the 22nd Shaukat Khanum Memorial Cancer Hospital Symposium, which is being held in the historical city of Peshawar. I hope you all feel well energized and rejuvenated after the lunch break. Although we are coming to the close of the symposium, but we still have got some very exciting sessions. One of which obviously includes the one that you're attending. That is the Sarcoma and Reconstructive Surgery session. We also have the last session, that is the prestigious Hassan Rashid free paper session, which is going to be the last but not the least. So we've got three exciting talks in this session. We'll introduce our speakers in a while, but first of all, let me ask the chair and the co-chair to please come to the stage. We have got Dr. Ilyas Rafi, who is the consultant orthopedic and sarcoma surgeon at Shaukat Khan Memorial Cancer Hospital, Lahore. So please take your chair. And we have Dr. Alina Sadaf, who is the consultant pediatric oncologist at Shaukat Khanum Cancer Hospital, Lahore again. So our first speaker is Dr. Joseph Pressy. He joins us from Cancer and Blood Diseases Institute of Cincinnati Children's Hospital Medical Center in Cincinnati, Ohio in US, where he is the director of the sarcoma and young adult oncology programs. He's also the co-director of the Young Adult Oncology Program and Solid Tumor Research Program. He serves as the institutional principal investigator for the Children Oncology Group Pediatric Early Phase Clinical Trial Network and the Sarcoma Alliance for Research through Collaboration. Dr. Pressy is also professor of clinical pediatrics at University of Cincinnati College of Medicine. Dr. Pressy will be talking to us about the approaches to the recurrent and refractory bone tumors. Can we have the talk for him, please?
We're going to focus today on Ewing sarcoma and osteosarcoma. These are the most common primary bone tumors. They typically arise in adolescents and also young adults. Peak incidence is around 14 or 15 years of age. Ewing sarcoma is often diagnosed immunohistochemically by staining of CD99, Fly1, and NSE. More importantly is the EWS-Fly oncogene, which is the hallmark finding in Ewing sarcoma. It's recognized that about 90% of Ewing sarcomas have EWS-Fly, another 5 to 10% have EWS-ERG. There are a variety of other well-characterized variant translocations that have also been associated with Ewing's. There's no prognostic significance between the different fusions. The genomic landscape of Ewing's has emerged over the past decade or so now with the advent of NGS. It's recognized that they're genomically simple tumors. They have a few structural variants that are relatively common. There are also a number of other genes that can be mutated, STAG2 and TP53 in particular, that are found in combination with the EWS-Fly oncogene. The amount of genomic complexity does correlate with outcome. Those that are more genomically complex, including single nucleotide variations and structural variants, typically do fare more poorly than those who have more simple tumors. STAG2 has been an area of interest, and it's recognized that the loss of STAG2 is important for the virulence of Ewing sarcoma. It's been studied both in humans and in animal models as well. There are a variety of other biological factors that are thought to be important for Ewing sarcoma. It's recognized that EWS-Fly, for instance, has substantial effects on chromatin remodeling, and this may potentially be an area of therapeutic targeting as well. LSD1 is a gene that is highly expressed in Ewing sarcoma and does correlate with outcome and can be targeted with a novel therapy that I'll discuss in a few minutes. Likewise, DNA replication stress and DNA repair defects are also recognized in Ewing sarcoma and may potentially become areas of therapeutic targeting as well. This is work from Alex Bishop's lab in San Antonio, Texas, who's demonstrated the accumulation of R loops that occurs in Ewing sarcoma. Likewise, work done here at Cincinnati Children's has also identified a subset of tumors based on IGF-1R expression that may be particularly susceptible to combinations such as IGF-1R inhibition along with WEE1 inhibition. Standard of care for Ewing sarcoma is compressed interval Ewing sarcoma therapy, which is VDC-IE, alternating over 14 cycles. The compressed interval is shown to be of advantage over standard 3-week interval therapy. Richard Fulmer at CHOP is the one who pioneered this work, and this is now considered the standard of care for both localized and metastatic Ewing sarcoma patients. Unfortunately, metastatic Ewing sarcomas are still associated with a very poor outcome. Patients, especially those with bone and bone marrow disease, fare dismally. And there's been no major advances over the past few decades. And so this is definitely an area of major effort still. Those with lung-only disease, however, can be cured. However, their prognosis is certainly worse than those with localized disease. High-dose chemotherapy with stem cell rescue has been studied in a variety of settings in Ewing sarcoma. And the one area where it's been shown to be of benefit is actually in localized patients, not metastatic patients, but it's a subset of localized patients, those who have either large tumors or poor necrosis at the time of tumor resection. And this was shown by the European group a number of years ago. And again, the one area where autotransplant has been of use in Ewing's. There are a number of regimens that are used in the setting of relapse. These include topotecan cyclophosphamide, irinotecan temozolomide, gemcitabine with or without docetaxel, and finally high-dose ifosfamide. Recent European study, the Recur trial, evaluated all 4 regimens head-to-head, and in a sequential manner, we're able to show initially that gemcitabine docetaxel was inferior to the other regimens, and then irinotecan temozolomide was found to be less beneficial than topotecan and cyclophosphamide or high-dose ifosfamide. And ultimately, high-dose ifosfamide was found to be the winner among the 4. And so this is giving us a pathway forward in terms of how to think about the frontline therapy in the setting of relapse, but also may be a little bit problematic when we think about using these regimens as backbones where for novel therapies. High-dose ifosfamide may be a little bit trickier to use than topotecan cyclophosphamide. Or even irinotecan temozolomide, but at least gets us a pathway forward as far as thoughts about frontline therapy once a patient does have recurrence. Other studies that have been undertaken in recent years, especially those that have been focusing on targeted agents, are fairly extensive, and so there has been a fair amount of interest in Ewing sarcoma. Namely, PARP inhibitors in combination with alkylators such as temozolomide had generated a lot of interesting preclinical data indicating that there was a signal there. Unfortunately, it has not paid off in humans. So all the clinical trials of either olaparib or BMN 673 in combination with temozolomide have failed to show a substantial impact. And this approach has been largely abandoned, unfortunately. Other agents that have been of interest include IGF-1 inhibitors. The Roche agent R1507 was studied and was found to have a response rate of about 15 to 20% in recurrent tumors as a single agent. But other IGF-1 inhibitors have basically demonstrated the same or worse outcomes in the setting of relapse. And so there hasn't been a lot of traction with IGF-1R inhibitors in Ewing sarcoma at this point. Ganitumab is a monoclonal antibody that targets IGF-1R receptor and was used in combination with chemotherapy in newly diagnosed metastatic patients, but was of no more benefit than standard chemotherapy, unfortunately. Autologous tumor vaccine study that was being developed by a company named Great Alice in Texas showed some promise in early data in humans, but was stopped by the company and is no longer being pursued, unfortunately, but was a very novel approach to Ewing sarcoma. Other studies that are either ongoing or recently completed include the ADVL 1522 study conducted by COG of NAB rapamycin, which is albumin-bound rapamycin in combination with chemotherapy, which showed some responses in Ewing sarcoma. TK216 is an inhibitor of the EWS-Y oncoprotein and had some very early promising preliminary data as well, but has not been published yet. I mentioned LSD1 is a protein that's highly expressed in Ewing sarcoma and affects chromatin remodeling. There is an inhibitor of LSD1 that's being studied presently as a single agent. CDK4/6 inhibitors such as palbociclib are being studied in combination with topotecan and cyclophosphamide in Ewing's. And finally, a new class of alkylators, trabectedin and lurbinectedin, are being studied as single agents and in combinations with PARP inhibitors. And there's some fairly promising preclinical data there in Ewing sarcoma specifically. Moving on to osteosarcoma, unfortunately, there's less progress here than there is with Ewing sarcoma. As far as the etiology, most of these are sporadic, but there is a fairly large percentage that are associated with germline predisposition syndromes, including RB1 and Lee-Fraumeni. Some others that are less common include Rothman, Thompson, and Werner's. Paget's disease, again, is seen in elderly patients, and a second peak in incidence in the 60s and 70s in patients with this disease. Obviously, ionizing radiation can also induce osteosarcoma. The pathology is dependent upon osteoid deposition. Our pathologists here in Cincinnati like to use SATB2 oftentimes as an immunohistochemical assay to help confirm the diagnosis. The genomics of osteosarcoma are far more complex than Ewing sarcoma and most other sarcomas for that matter. There is no recurrent translocation, but there are often very many random translocations that are found within any particular osteosarcoma specimen. But again, these are random, not recurrent. They're not helpful diagnostically and unfortunately not therapeutically either. Compared to other pediatric cancers, osteosarcomas are generally more complex, more on the level with inguinal rhabdomyosarcoma when it comes to single nucleotide variations, and even more complex when looking at structural variants or chromosomal changes. Other alterations that are thought to be important for the virulence of osteosarcoma include alternative lengthening of telomeres, and then when combined with telomerase expression can be a very potent biomarker of prognosis. Why are osteosarcomas so complex is not clear, but one theory is that there's an event called chromothripsis, which is a single chaotic event that leads to a very complex genome that's been modeled in osteosarcoma as well as a few other cancers, including chondrosarcoma. And the idea is that this one single chaotic event can lead to hundreds of rearrangements within a single tumor cell. And this is implicated in the pathogenesis of osteosarcoma. And this genomic complexity likely leads to difficulties with chemosensitivity and quick development of resistance in osteosarcoma, unfortunately. It is recognized that chemotherapy is beneficial in osteosarcoma compared to historical controls, where patients with localized disease almost universally recur with lung metastases if they're not treated with chemotherapy. A very early study by Norm Jaffe showed the value of chemotherapy in patients who had had adequate local control. And the idea being that we recognize that almost all of these patients have micrometastases at diagnosis that do need to be treated with systemic chemotherapy. Our standard as of 2023 remains MAP chemotherapy, and not so different than the systemic regimens that were being used in the late 70s. And so this is still the standard of care today, along with surgical resection of the primary tumor, as well as lung metastases when those are encountered. Histologic response is very important in osteosarcoma. We recognize that the tumors that have more than 90% necrosis are associated with a favorable outcome compared to those with less than 90% necrosis at the time of resection, typically conducted about 10 weeks after the start of therapy. We've recognized that this becomes less prognostic as the intensity of chemotherapy increases or decreases and the duration of pre-op therapy changes. So it's not a perfect biomarker, but as of 2023, it's the most useful biomarker of response that we have at this point. There are a variety of studies that have been conducted by consortia to really improve upon MAP chemotherapy. A combined CCG-POG study around the turn of the century was studying MTPPE in combination with chemotherapy. Unfortunately, it was a fairly complex design study, 2x2 factorial design, where the chemotherapy backbone varied between arms, and patients were randomized to either receiving MTPPE or not. The initial follow-up data did not seem to indicate that there was any benefit, but a long-term follow-up eventually did identify a statistically significant difference between those who received the experimental agents versus those who did not. Unfortunately, the FDA here in the US was not adequately impressed to approve it, but it is approved by the European Drug Agency. It's not something that we try to integrate into our therapies at this point, and it's not really getting any major focused investigation these days. Other studies include the URAMOS study that had two parts. One was for patients with better than 90% necrosis, and those were randomized. Those patients were randomized to either receiving an interferon maintenance therapy or standard MAP. Unfortunately, interferon did not seem to add any benefit, although the study was flawed by the fact that about a third of the patients assigned to interferon dropped out of the study before completion. But at this point, there does not seem to be any traction for interferon moving forward. On the other component of the study, those patients who had less than 90% necrosis at the time of resection were randomized to either receiving MAP or MAP plus ifosfamide etoposide. Ifosfamide did not add any additional benefit to either those who were localized at diagnosis or those who were metastatic at diagnosis, unfortunately. And so ultimately, MAP remains the standard of care for both patients with localized disease, metastatic disease, as well as those who, both those who have better than or less than 90% necrosis at the time of resection. For relapsed osteosarcoma, surgery remains the mainstay of treatment. We do recognize that the time to relapse is very important. Those who relapse more than 2 years out do better than those who relapse sooner. Likewise, the number of metastases is very important, especially when evaluating the number of lung metastases. Those with oligometastases fare better than those who have more metastases. Those are logical conclusions, and but that has been proven through various retrospective studies that have been undertaken in the past. Established medical therapies for osteosarcoma are a little bit more controversial than it is for Ewing sarcoma. There are a variety of regimens that are used: ifosfamide plus etoposide, gemcitabine plus docetaxel, and more recently regorafenib, none of which have been shown to impact overall survival. But even in the near term, the benefit of these chemotherapies are a little bit less clear. Ifosfamide is often used as frontline therapy in the relapse setting, but can be quite toxic. Gemcitabine, and with or without docetaxel, is often used as well, but the benefit is less clear. And even retrospective studies have not done a good job of supporting the use of gemcitabine in osteosarcoma. And then regorafenib is a newer drug that has been shown to be at least superior to placebo. COG recently did a retrospective study of 7 phase 2 studies of osteosarcoma to get a better sense of what the success has been in experimental therapies and relapse in the relapse setting. Unfortunately, the outcome has been very poor, as you can see here in the Kaplan-Meier, with a median progression-free survival of 12% at 4 months. The benefit of this analysis is that this now provides a new bar for future studies to indicate which of those may be of promise. And again, 12% median progression-free survival is obviously a very low bar, but that is the current measurement by which new studies will be compared. The other key component here is that RECIST criteria has been found to be a poor way of measuring success of studies, and actually the median progression-free survival is now the way forward, given that osteosarcomas, even when they're responding to therapy and becoming necrotic, typically do not regress. As I mentioned earlier, regorafenib had been studied in osteosarcoma in recurrent setting, and at least compared to placebo, has been found to be superior, and it has gotten some traction moving forward, but exactly how to integrate it into new therapies has been somewhat problematic, given that it has its own unique spectrum of toxicities. Other studies that have been undertaken include studies of zoledronate, a bisphosphonate, Herceptin, which targets HER2, denosumab, a RANK ligand inhibitor, CDX-011, an antibody drug conjugate, pembrolizumab, the PD-1 inhibitor, and then nivolumab, another PD-1 inhibitor in combination with regorafenib. All these studies have failed to show a benefit and are no longer being pursued, unfortunately. An interesting approach to osteosarcoma was described by the Sweet Cordero lab at the University of California, San Francisco, where they took a very large library of PDX models and studied both rearrangements, so translocations, and gene amplifications to identify the best targets for novel therapies. And the conclusion was that it's actually amplification within osteosarcoma that may be the more attractive target for novel therapies, and much more traction there than would be found with the rearrangements. And so this figure shows that, again, a number of genes that are amplified with targeted therapies that were available, and we're able to show some benefit in this approach. We recently published a case report of a patient using that same approach where she had CDK6 amplification, and at the time of relapse was treated with gemcitabine plus palbociclib, which is a CDK4/6 inhibitor, and had a very surprising dramatic response by PET scan, and this differentiation effect where it has seen this calcium deposition in her pulmonary metastases. It was only experienced over the duration of the effect was only about 9 or 10 months, but it was a dramatic effect, and this may point an interesting way forward when it comes to thinking about ways of treating high-risk osteosarcoma with a mild chemotherapy backbone combined with a targeted therapy driven by amplification data from the NGS when that's undertaken. Another study that is of interest right now to our group is the PEPN 2011 study being conducted by Children's Oncology Group. It's a study of tegavivint, which is an inhibitor of transducin-like beta, which leads to degradation of beta-catenin and inhibition of the Wnt pathway. As a single agent, it's been shown in preclinical studies to have a really dramatic effect on osteosarcoma, both on the volume of a xenograft model and the effect on metastases as well. And so this is being studied as a single agent, and it's currently in a phase 2 expansion. The hope is that it will be combined with doxorubicin in future studies. Cellular therapies are also getting substantial attention in osteosarcoma. Most of these are targeting GD2, which is not only expressed in neuroblastoma, but is also expressed in osteosarcoma. More to come here. So that's a quick overview of osteosarcoma and Ewing sarcoma and some of the recent studies that have been conducted and some of the more promising agents moving forward. Happy to take any questions or any discussion that follows. Thank you very much.
Well, thank you very much, Dr. Pressy. We'll take question and answers at the end, and we're hoping that Dr. Pressy will be joining us online for the Q&A session. So our next speaker is Dr. Iona Nixon. She is the Clinical Director Oncology at the NHS Greater Glasgow and Clyde. She specializes in bone and soft tissue sarcomas, GIST, and clinical innovations. Dr. Nixon is a professor at Business School, Strathclyde University, and an honorary clinical senior lecturer in Medical School, Glasgow University. She's also the Cancer Innovation Lead at West of Scotland Innovation Hub. Dr. Nixon will be talking to us about managing rare cancers.
Hello, everyone. Thank you for your so kind invitation. This is the second year I'm invited to this symposium, and I had really hoped to be today with you in person, but facts of life and work have not allowed to. Some of you may have heard my talk a year ago, and this time I will touch on aspects of sarcoma management, which is a rare cancer, hence the title of this talk, that we have discussed last year, but I will also showcase how our services and patient care have evolved within a year's time. There is a quote from Hippocrates that says, where there is a love of medicine, there is a love of humanity. And we're all here to attend this symposium as we want to improve the lives of people with sarcoma, with rare cancers, directly or indirectly. My name is Joanna Nixon. I'm a clinical oncologist at the Beatson, West of Scotland Cancer Centre in Glasgow, and I specialise in sarcomas. I've been the clinical lead for the Scottish Sarcoma Network since 2015, and I'm also newly appointed as Clinical Director for Oncology Services in NHS Greater Glasgow and Clyde, which enables me to look at the broader picture of where rare tumours sit in the broader service landscape. I promise to discuss why, what, and how we manage people with sarcomas. And to set the scenes, I will start with my big why, taking you on a time capsule in Greece in 1993. When me and my best friend are watching this movie, The Groundhog Day, now you may think that movie is a comedy, so all cheery and jolly. However, that wasn't the case. My friend was about to start chemotherapy for a rare bone cancer. In fact, he was due to be admitted for chemotherapy on the next day. But I knew very little, if at all anything, about bone cancers. Seeing healthcare through the eyes of my friend as a carer, being on the receiving end, was an eye-opener for me and influenced my career, the way I view care, and my decision to become a doctor. This experience showed me people with a rare cancer require a lot of support, which should be tailored to their unique needs through the journey from diagnosis through treatment, follow-up, and survivorship. So when we think about sarcomas, all of us treating this rare disease, there are two things that cross our minds: rarity and diversity. Sarcomas are rare and diverse. They can happen in any anatomical part of the body and at any age group, reflecting on how needs of patients can differ. They ought to be treated by teams with expertise. They ought to be treated in specialized centers, ought to be managed by a multidisciplinary team with expertise in managing these conditions in a clinical network which works in partnership with wider networks, clinical and non-clinical. And when we talk about clinical networks, these are groups, linked groups of healthcare professionals and organizations from primary, secondary, and tertiary care that work in a very structured, coordinated manner, unconstrained by existing professional and health board boundaries, to ensure that we offer equitable, high quality, effective services for our patients. So we say clinical networks are important, and here is why, here is the evidence. Many of the examples I will be using come from the French sarcoma group that are very dynamic and great in terms of publishing their work and their data. So we know that there is significant impact on local relapse-free survival and relapse-free survival when patients are being discussed at a specialized multidisciplinary team forum, part of a wider network prior to first treatment. We also know that when surgery is performed in reference centers, there is significant impact on survival. When patients are operated in reference centers, there are fewer reoperations and high rates of R0 resections. And that also improves outcomes, namely improves survival when surgery is performed in reference centers, part of the network. Moving on to research, a known study to all, doxorubicin alone versus doxorubicin plus ifosfamide for first-line treatment of advanced or metastatic soft tissue sarcoma, a randomized controlled phase 3 trial where 38 hospitals participated in 10 countries from April 2003 till May 2010, and 228 patients were recruited. Also, the Getty study, where 257 patients were recruited through 24 UK hospitals and one SAC hospital. And more. Clearly, we can't perform research in rare tumors such as sarcomas alone. We have to collaborate in a global fashion to enable us recruiting to clinical trials. So we have seen some data, some evidence on how clinical networks can improve care for patients with sarcomas, and why we actually need to work within these clinical networks to recruit into clinical trials, learn from each other, and support best care for our patients. And this nicely brings me to all of us here today on a question to ask ourselves. How do we value networks? What is the value of networks in rare diseases? What does really matter? So to address this question, I reached out to my diverse global network, including colleagues, patients, carers, academics, charities, and here is what they have said. Networks are vital to the study of rare cancers and have markedly changed clinical practice. United together, we can learn more about this rare and diverse disease, and we stand better chances of giving a better response to our patients than we just don't know enough about this to guide decision-making. We need close and trustful international collaboration to improve care for patients, and that can only happen through networks. That can only happen through collaboration. These are diverse and are clinical and non-clinical. Through networks, we can offer patients peer support, and we can also gain a better understanding of their unique, complex needs. We can understand the disease better. Networks are fundamental for personalized and realistic medicine to be realized through shared learning, research, and clinical innovation. From clinical networks, starting from a local multidisciplinary team discussing optimal management to wider clinical and non-clinical networks, all are equally important to patient care according to patients. Compassion is also mentioned as a core value of healthcare professionals and as one of the networks aiming to optimize care for patients. In very simple words, networks connect, and this is not just valuable, but essential to patient care, especially in rare diseases such as sarcomas. And all comments shared by the sarcoma community are so rich, thoughtful, and thought-provoking. Networks are valued, teams are valued, but it is also the values of networks that make them more effective in driving patient care forward, plus enabling us to understand why, what, and how. And all that has been more evident during the pandemic and now that we are into the recovery phase post-COVID. But where are we now? We've been through a pandemic that posed a number of challenges and changes upon healthcare services, humongous pressures. We're now in the recovery phase, and the landscape in the UK and globally is rapidly changing. Scotland is no exception. There's a word for it coined many years ago by the military, and this is VUCA. And in many respects, VUCA is the new normal. And in this climate, the urgency for change is the driver for more collaborative work, building more bridges between existing networks and actually opening the dialogue like the one that we have today to share learning on how to support people with rare conditions such as sarcomas. I know I promised to discuss why, what, and how. And indeed, I shared my big why we need to treat sarcomas in specialized teams, and why and how networks are important in the treatment of these conditions. What actually shared as important amongst colleagues in the sarcoma community. Now it is time to focus more on the disease side of things, as sarcomas are so diverse and complex. For example, we have over 80 subtypes of soft tissue sarcomas, all behaving as distinct diseases. And amongst these diseases, we see the good, the bad, and the ugly. And we really need to support research, which cannot be done without collaboration at global level to recruit into our clinical studies. Back in 2019, in recognition of how important supporting and leading on research is for rare cancers such as sarcomas, we developed the National Sarcoma Research Strategy, which was not existing before, to enhance research opportunities for sarcomas in Scotland, fostering collaboration with other research networks. Here you see the Beaton Cancer Centre, where I am based, which is a CRUK center with a renowned CTU and a rich portfolio of clinical trials, and of course, for clinical trials focusing on rare conditions. And here you see some of the studies related to sarcomas. We have a diverse trials portfolio at the Beatson, both academic and pharma-sponsored clinical trials. And our vision in the era of precision oncology is one day to be able to offer every patient at least one clinical trial. On the research front, I'm delighted to be leading on the clinical data collection for the Sarcoma Accelerator Consortium, which is a 5-year ambitious project aiming to provide a digital hub of clinical and research data on sarcomas, as well as cellular and animal models. This is to help us predict and test patient responses to drugs for high-risk sarcomas using artificial intelligence. And as I mentioned before, COVID brought up, imposed a number of challenges and changes upon services. And one of the changes is the implementation of telemedicine. So we collectively did a project to assess patient and professional views on the impact of telemedicine for sarcomas. And this was in collaboration with Professor Robin Jones and his team at the Marsden, as well as the University of Strathclyde. What we found was that experience of both patients and providers was broadly positive, with patients and providers being receptive to the long-term implementation of telemedicine. So taking this forward and knowing that there are no major objections from staff involved, and very importantly, patients and families, and bearing in mind that there is no one-size-fits-all approach, we continue with telemedicine as and when required. And in fact, a lot of the clinics that we do, for example, for GIST TKI prescribing, have moved into a model, a telemedicine model. So we do virtual consultations or call patients. Another important thing to note is that the British Sarcoma Group guidelines have been updated for soft tissue sarcoma, bone sarcomas, and GISTs, and have now been shared within key groups in the UK for comments and endorsement, and hopefully will be available on our website soon. And I suppose it's common knowledge that ESMO guidelines are available, and it's important that we all refer to these when we manage these tumors. As a radiation oncologist, I would like to talk a bit more about radiotherapy and how we have progressed over the last year in our hospital at the Beatson. So I'm very pleased to report that we are one of the very few centers to use MRI planning for sarcomas, and that's relevant to whoever in the audience is a radiation oncologist. And that improves accuracy of our radiotherapy volumes and overall quality of our treatment. At the moment, we are collecting data on the patients we treated, and hopefully we'll be able to report the findings at ESTRA conference. And you see on this slide very briefly the indication to treat soft tissue sarcomas and the diversity in terms of where these can occur in the human body. Still on the radiotherapy side, standardization is really important. It's really important that we have a consensus approach to radiotherapy, how we volume, how we plan cases, how we immobilize patients to improve accuracy. So to the direction of standardization, the Royal College of Radiologists evaluated the role of peer review of radiotherapy planning in routine practice. And this is an important development and an essential part of the radiotherapy pathway for every patient. It provides quality assurance to standardize the volumes, to reduce scarcity, and also ensure safety through implementation of governance processes. And of course, last but not least, offer an excellent opportunity for shared learning and expertise, mentoring, and monitoring of practice. So in our practice, once a week, we have a peer review, and we meet to discuss our radiotherapy volumes, our plans, And this is a multidisciplinary, I should say a transdisciplinary team with input from dosimetrists, radiation physicists, scientists, MRI radiographers, smoldering radiographers, and treatment radiographers. And that is essential to ensure radiotherapy quality. And I'm sure that this resonates with everybody here today. We're all devoted to personalized care, and in Scotland at the Beatson we use the What Matters to You tool for every patient. We know it takes only 90 seconds for a patient to tell us what is most important to them. And this tool applies not only to patients, but to our colleagues, our co-workers, even more important during the pandemic and now in the recovery period with VUCA being the new norm. And to bring you all more into my world and going through why, what, and how, I have chosen some patient stories to share with you today, starting with the story of Liz. Liz is a 16-year-old girl who presented to her MDT with an osteosarcoma, and you see her diagnostic scans here, including her bone scan. I should mention she did not have systemic disease on CT, chest, abdomen, pelvis. You can imagine how difficult it is for a 16-year-old to receive this news about a complex disease and complex treatment required, diagnosis, and actually cope with intense chemotherapy for an osteosarcoma, and then complex surgery, which in her case was rotation-plasty. To make things more complex, Liz experienced trauma a few years before her diagnosis, as she and family were in Manchester during the bombing attack, which resulted in her not wanting initially to fully engage with us. She required a lot of support by the clinical nurse specialist team, psychology services, and all the supportive care that we could put in place. And I'm really pleased to share that she has not just coped with treatment, but she's now well, as you will see in the next slide, where I share a video from her early days of rehabilitation. What you see here is actually Liz walking, and that is about 9 months ago. And further progress has been made since then, and she's actually well and on follow-up now.
Hi there. My name is George Keel, and I'm on my second.
diagnosis or a serious life event. So I know you well as your oncologist, and I would like to introduce you as someone very inspiring with amazing strength and will and resilience. But how would you like to introduce yourself?
Just turned 30, so I've been spending the last year of my 20s going through one of the toughest sort of lessons I could possibly learn in life. So I'd introduce myself as Roisin, a survivor of cancer, and yeah, I'm currently sitting at home, thankfully, due to the treatment that I received at the Vitsen. So yeah, I usually work in hospitality and a lot of face-to-face roles, so I haven't sort of taken work back on yet, unfortunately, but I'll get there. But yeah, hospitality is my forte, so.
Yeah, it has been a challenging year. Your diagnosis coincided with the pandemic. So how did you experience all that, Roisin? Can you tell us a bit about your treatment? So what kind of treatment did you have so far, and whether COVID affected any part of the journey?
So I'd been through around 10 weeks of chemotherapy, pre-surgery, and then I had basically my jawbone removed from here to halfway, and a lot of the soft tissue around it as well. So after that, I was then put onto, I think it was around 18 weeks, maybe 16 weeks of chemotherapy then afterwards, alongside that with immunotherapy, which I'm receiving for another 6 weeks. My chemotherapy finished in October, so that was it was methotrexate, doxorubicin and cisplatin, sort of on a cycle. So that was enough fun.
A lot of time with us in the hospital and the team. And during the pandemic, it has been challenging for all of us. How do you think did it have any impact on you or the way you experience care?
Mainly, I mean, at the beginning, the distancing was tough. I really needed that sort of comfort. So my first few weeks in chemotherapy, I was in for like around 5 days, 4 or 5 days. So to not have any visitors, and obviously nurses have to keep their distance as such as well, and everyone, yeah, I just felt a bit more difficult. But because I've never been in hospital before this, I didn't really have anything to compare it with. So I really quickly got used to it. And not long after, sort of a few weeks afterwards, I think they slowed it down a bit. You're allowed one visitor up to the ward. So my mum was a great support for that. So yeah, I mean, in terms of that, I didn't really notice a difference. I've probably found the care to be better, possibly, but more because there's not so many distractions. I think everyone was more focused on the job in hand when it was happening. So, yeah, I actually felt the care and the reason from yourselves and from the nurses was second to none.
Thank you so much. I was about to ask you what you thought the team did well regarding your care. What do you think went well?
The compassion from everybody, and the understanding, obviously, in the role, and that gave me security and how my treatment was going to go. But yeah, it was a huge comfort to have yourselves and Dr. Kerry and Dr. White and everyone just being so compassionate and understanding. There wasn't a moment where I felt our time was rushed. There was always time given for questions and for exploring new ideas. So that definitely helped along the way.
And is there anything that we could have done better? Any areas that you think we should be improving? Be honest.
Personally, I kind of struggle to find anything in regards to sort of your team, the team that dealt with me, the oncologists, the consultants were all fantastic. It would probably be the hospital food that would be the only downfall, but that isn't your sort of remit. So unfortunately, but no, I genuinely I couldn't have faulted it. If anything, I would have had someone with me 24 hours a day for conversations and tea and biscuits, but that's not possible. So.
That's because of COVID, primarily.
Yeah.
And in terms of your treatment, what part did you find the most challenging? If you try to break it down, what part of it challenged you the most?
The side effects, the cumulative side effects, really. I found once I knew that there wasn't much chance of there being cancer in my body, I kind of let my guard down quite a lot. So the effects, the cumulative sort of effects of it they kind of went hand in hand. But once I knew that the cancer was away, it took more of a mental toll on me. It was harder to deal with because I knew that every dose of chemo was now just hitting healthy cells as well as the floating cells that might be there. So I think it was more towards the end that I really struggled with
I think we have to end this presentation for the sake of time. We have
now
to.
we're getting towards the end of the treatment, which is
Thank you very much, Dr. Nixon. Now moving away from the medicine side of the sarcoma care, and I can see a lot of surgical faces. So we're moving to the surgical side of it now. We are honored to be joined by Dr. Mr. Mohammad Atta Siddiqui, who is the consultant sarcoma and orthoplasty surgeon at Nafil Orthopedic Center, Oxford University Hospitals. Mr. Siddique's main areas of interest, both in clinical practice and research, are pelvic sarcoma and hip and knee reconstruction. He has been involved in various teaching courses, including the AO, trauma, and ATLS. His main passion is global health. Currently, he's setting up a global sarcoma education program for lower and middle income countries. He has been invited to join the Education Board of International Society of Limb Salvage Surgery to develop a basic sarcoma course for resource-limited countries. I would ask Mr. Siddiqui to present his talk on pelvic surgery in sarcoma. Thank you.
Bismillahirrahmanirrahim. Assalamu alaikum. I would like to extend my thanks to the Shaukat Khanum Cancer Symposium organizers for providing me the opportunity to be talking to you today. The talk assigned to me is related to pelvic sarcoma surgery, and I would be talking about what is new, which is guided resections, where we are now and where we are headed. My name is Arthur Siddiqui. I'm a consultant orthopedic surgeon, sarcoma and arthroplasty at the Nuffield Orthopedic Center in Oxford. With respect to this presentation, I have nothing to disclose. Now, whenever I talk about pelvic sarcoma, I'm always taken back to first year of my MBBS, where this particular guy has made a lot of difference in how we understand anatomy. I still have his atlas in my library, which I often refer to whenever I have to go back and visit good illustrations. Now, what we do remember from that complex anatomy in this difficult area that is the pelvis is that it is a very complex, bony, three-dimensional structure, which is surrounded and bound together by very strong ligaments that are often very hard to cut and resect. But also within that bony pelvis is a clockwork of very, very important structures, including viscera, large blood vessels, and the peritoneal contents itself. Now, injury to any of these structures can be devastating for the patient, not only make your own operation difficult, but also make the morbidity of the surgery very high. Now, when we look at sarcomas, besides the already existing complex anatomy, large tumors within the pelvis can be difficult to navigate around. And sometimes you can end up looking a bit like that, the picture on your left, where there are multiple ways to go and you really can't decide which plane is the best to dissect in, which angle is the best to cut your bone in. Often you require navigation when you're lost. And I think that is what I'm going to talk to you about today. Now, if you look back at computer-assisted pelvic tumor resection, it is not a new idea. This has existed for a very long time. Back in 2011, actually even earlier than that, 2007 is when Shaukat Khanum, the gentleman shown in the left picture, and his then disciple Casey Wong started their work with computer-assisted pelvic tumor resection and reconstruction. They, at that point, not only resected the pelvis using 3D guided jigs, but also part of their innovation was constructing a custom-made prosthesis which went in exactly into the defect they took the tumor out of. Now, their work was further revalidated within the UK in Birmingham by Lee Jays, and who then probably presented the biggest series of their time, and they showed that it does reduce the risk of intralesion margin, as well as reducing the local recurrence rates in patients with pelvic or sacral tumors. Follow-up to their work, which was published in Oncology, they then published in the BJJ recently in 2019, noting their long-term results of the first series they had presented. So what they found was soft tissue margins have to be adequate to reduce local recurrences. So in the long-term results, they did find that they did have some local recurrences, but those were the tumors when the soft tissue margins had not been adequate. Now, in the series published from Birmingham, they have shown that a 2 millimeter margin, if it is precisely cut and uniform and free of tumor, is good enough. We normally accept a 1 centimeter margin, which is 10 millimeters, but now we know from this work that even going as close to the tumor as 2 millimeters should still be okay. Now, this is never planned. This is what we do take as a very close margin, but they have not shown any local recurrence with 2 millimeter bony margins. So what's the next step? Now, we know navigation has existed for over about 2 decades. It's going to be 2 decades since we have started using navigation. 3D printing has completely revolutionized all aspects of surgery, whether it's orthopedic surgery, whether it's maxillofacial surgery. It is just coming up as the new entity in medical technology the world over. In fact, it is called the 4th industrial revolution, where 3D printing is being used for reconstruction, for manufacturing space equipment, for manufacturing day-to-day things at your home, where people have now got access to 3D printing, portable printers that you have at home. In fact, next to me in the room, right at the back, is a printer that my daughter uses. So it is becoming a common thing to have 3D printing. Now, why not use this technology to our benefit? So again, Casey Wong and Shekhar Kumta pioneered this, and their first report was published in 2014, only 7 years after their work on navigation. Now, as the world was still learning navigation from these two, they had started work on the next step, which was 3D printed custom implant after pelvic tumor resections. So what we did, I think in the UK, Oxford has the sort of badge that we pioneered 3D printing for pelvic sarcoma surgery. Now, we looked at our data from 2018 to 2022. We started probably doing the first case was performed at the end of 2017. But from 2017 to 18, there were only about 2 or 3 cases were performed, actually up to 2019. So 2019 is when I started, and this I took on as a project. Basically, we were trying to develop a system where we could get access to these 3D printed models and jigs for use in pelvic sarcoma surgery. Unfortunately, as you know, March 2020, COVID struck. And then we were all stuck as to, no projects were happening, funding was down. So we decided to go to a local manufacturer of 3D printing models who was actually working for an educational project with the University of Oxford. And we went to them and said, could we start a completely new clinical system to develop this with you? And they said yes. So subsequently, we've done about 35 cases, and these cases are not only performed at the Nuffield Orthopaedic Centre, but also at the Royal National Orthopaedic Hospital in Stanmore. If you look at our case distribution, obviously, because it's the pelvis, a lot of patients had chondrosarcoma as their primary malignant bone tumor, but we also had a significant number of patients with metastases. Ewing sarcoma formed our third most common group. Now, how we do this is very important to understand. So the pictures, the 2 pictures at the bottom left are Jay, our engineer. She's absolutely amazing. We would normally send her CT scans and MRI scans requested through the PACS, which then are transferred digitally, that she would generate a 3D model of. And via Zoom or Teams link, we would be able to review these models with the scans alongside it to determine whether they do match where we think the tumor is. So there's a lot of planning, and a surgeon and an engineer sit together to discuss that plan. Now, if we look at the NOC, that facility is housed literally just next to us. So we are quite at ease. We can walk to them whenever we want. If you look at the renderation on the right, this is showing a tumor in the posterior column and into the acetabulum, where we were planning a partial acetabular resection so that we could actually build this up with a hip type reconstruction. So within that bone, the red was the tumor, the yellow is the margins, and then the green shows where our cuts would be. And eventually, the printer would print out cutting jigs, which will be held by pins onto the bone to guide the saw to go exactly where we want, which is outside that margin. So this is how we currently practice our pelvic resections, which has shown us some very good results. Now, just to show you some cases, this was a chondrosarcoma within the posterior ileum. Now, normally, you would be worried about resecting the SI joint because you would not know the precise location of the tumor. And to try and go over the conventional resection, you would normally be destabilizing a lot of the posterior SI joint. Now, that will make reconstruction of the ring difficult. Patients often come back with pelvic pain, posterior pelvic pain, and eventually, as a late complication, they get migration of the pelvis, hemipelvis, superiorly because of lack of an intact SI joint articulation, and they also get symphositis very commonly. Now, in this young patient, we were able to just take out a shark bite from the posterior ilium using a 3D printed jig, and as you can see on that photograph on your lower right, that the tumor came out exactly the way it was planned. Now, this was a very complex case, I would say. This was aggressive cervical cancer that had invaded through the pelvic side wall into the groin, right down into the thigh. And this was truly a multidisciplinary case with gynae-oncology, vascular surgery, plastic surgeons, and orthopedic surgeons all involved. So as you can see, we used a medial approach. And again, in this particular case, no jigs were manufactured, but a 3D model was used. With this case, we could demonstrate that with these models, not only planning in an MDT setting is easy, and as you can see on the photograph, the plastic surgeon has got the model in hand, so he's evaluating where his flaps would be, where our incisions would be, and then the gynae-oncologist and surgeon are discussing. So this was a preoperative planning meeting where the model was really useful. And as you can see, it is also useful to orient tumor when it goes to the pathologist. So we normally send the model with the tumor, and it really helps the pathologist orientate the specimen and give us precise margin results. Again, this was I can't even remember what sarcoma it was, but it was a really rare one. I think it was a hemangioendotheliopericytoma. Most of the pathologists here would know what I'm talking about. But anyway, it was a rare soft tissue sarcoma that presented with a bony lesion. And again, if you can see, here we have used a transparent resin within the pelvic model to show us where the tumor is. And the soft tissue component of the tumor is also shown extruding from the pelvis that we needed to take into account. What also you can see on this jig is that guide here, which shows where the guide pin for that hip replacement. So that's a lumic cup that we have used, and this shows exactly where that guide pin would go. I think I'll probably use this. Yeah. So that's the lumic cup, and that jig is designed to take the guide pin for the lumic cup. Now that's a resected tumor, which is exactly like this section that the jig wanted to take out. Now, if you look at our results, so we have had absolutely no positive margins. There was one positive soft tissue margin, which was an intraoperative leakage onto a myxoid chondrosarcoma. And all of us know that this is really terrible disease. One cyst you touch and it punctures and you've got a contaminated field. Average duration of stay was 12.3 days, whereas average operating time was 295 minutes. Now, a lot of you would probably ask me this question later, and I'll answer it now, is how does this compare with other modalities such as navigation? Now, it's really difficult to compare because this is a really heterogeneous group of patients. 35 patients, not a large cohort. And patients from other centers have got different surgeons, so there are too many biases. But we have sort of compared this data to our conventional resections, and we do find that the duration of stay has significantly reduced, and the operating time has also reduced. But again, we can't really statistically compare because these are both very heterogeneous group of patients. Average blood loss was about 2.2 liters with a transfusion requirement of 1.7 unit. We had adverse events in our 35 patient cohort with 3 vascular injuries, 2 visceral injury, 1 root damage, as I said, 1 intraoperative tumor leak, and 1 local recurrence, which was exactly in that patient. Very important to see what structures we saved. Acetabulum, hip joint, enabling easy reconstruction, and periacetabular bone, again, very, very important to all orthopedic surgeons. to try and reconstruct the hip to the best possible functional level. We have saved the posterior pelvis articulation with the SI joint. We have definitely saved the ureter and the internal iliac vein in certain settings, as well as some visceral structures by using 3D printing. Now, if you generalize the results from our sort of short cohort, a short study, within the limitations, we think that 3D models enhance understanding of tumor anatomy, and custom jigs allow surgeons to work by limiting unnecessary exposure. Therefore, they limit the surgical dissection time. They limit the overall operative time. They also prevent excessive blood loss, and they enable faster rehabilitation, and probably the patient gets out of the hospital much quicker. Now, obviously, a larger cohort, a longer follow-up, and ideally a case-controlled study would be required. However, I think we are far from there. Now, looking at the advantages over navigation, I think the main advantages are that all the planning is done outside of theatre. They're easier to use rather than understanding complex navigation hardware and software intraoperatively, which is obviously a very steep learning curve to it. The 3D printed model can also be sterilized and give the surgeon orientation and tactile feedback if you use it on your operating table. And surgeons who have converted from navigation to 3D printing say that they can now concentrate more on the patient who's in front of them on the table rather than looking at the screen and gadgets. The disadvantages obviously are that there is a recurrent cost associated with producing this, and therefore within the NHS, sourcing funding is difficult. Now in Pakistan, I believe the funding would be transferred either to the charity, for example, in Shaukat Khanum, or perhaps to the patient in a private setup. So where we are heading from here is, my whole vision is about combining navigation and 3D printing. So essentially we will do the same planning, and we are now working with Brain Lab with augmented reality systems, where you would actually wear one of the virtual augmented reality systems. And then when you look into the patient, you have to have the superimposition of the tumor into the patient. Now, they already have an application coming out for neurosurgery and spinal surgery, hopefully by the end of this year. And by mid of next year, we hope to bring pelvic surgery into the realm of augmented reality systems.
Do not believe everything your GPS tells you. Case in point, a Canadian woman who followed hers right down a boat ramp into Lake Huron. She actually had to roll down her window quickly and was able to climb out of it and swim to shore. It was a dark, foggy night. And that water, by the way, 4 degrees Celsius. Oh, yeah. Good job.
Just on a lighter note, small news item. I think what is really important with all navigation systems and all computer generated models, whatever you use, if crap goes in, crap will come out. So I think you have to invest in time and money in R&D, and especially the people you've trained. Now, this company that I work with, I have trained their engineers. They know their anatomy now. I've taught them anatomy, actually, basic anatomy. So you have to invest in human resources. You have to spend time, and you have to make sure that the quality of the data that goes in, which is your MRI and CT scans, are very well structured. You get the best resolution, and you sit down with them and plan well. Otherwise, you will get bad jigs. You will have intraoperative positive margins, or even sometimes you can't use jigs because they don't fit on the bone and you can't really use them clinically. Thank you so much from Oxford, and I would welcome any questions from the audience.
Thank you very much, Dr. Atta Siddiqui. The floor is now open for question and answers. Please feel free to ask questions, or if you have any comments, please.
I'm Dr. Abdul Wahid, oncologist from Rahman Medical Institute, Peshawar. Your presentation regarding this pelvic surgery was very much what they call it, encouraging, especially the 3D. My question is that we had a couple of cases of embryonal rhabdomyosarcoma. As you know very well that these are the patients that embryonal rhabdomyosarcoma occurs either in the head and neck or in the pelvis. We had a couple of cases in the pelvis, and they were very much advanced cases. One of them was having a tumor size of about 12 into 12 centimeter, which was pushing the urinary bladder. He couldn't pass urine, he couldn't pass stool. So we had to do suprapubic cystostomy. Well, we started with the chemotherapy. That's the new adjuvant chemotherapy. The response up to 6 courses was very well. The problem was that if we were going to have a resection, that's the we asked the orthopedic surgeons. They said that it's in the midline, and from the beginning it was diagnosed as a case of prostate cancer. So it's lying in the midline, having resection, total resection, we will be having problem in the futures. So we, what do they call it? They did a debulking surgery, not total resection, which was followed by external radiotherapy, and the patient was very well for about 1 year, but has been lost since that time. He was an Afghan patient. I would request your opinion in regarding such cases and your experience, please.
Thank you very much for the question. It was a very long one, so I'm not sure if I completely got the picture, but I think you're talking about rhabdomyosarcoma. As far as, yeah, we do deal with rhabdomyosarcomas, and yeah, they're very aggressive tumors. I'll just talk about general principles here. I think what I'm trying to say is, we know that in sarcoma work, closed margins in pelvic bony resections is acceptable, but you have to have a good soft tissue margin, which is quite critical. With respect to my talk, I would just stick to the, again, use of the 3D printed models for getting a tactile feedback, and they help you operate. In terms of your patient, again, we do deal with very complex cases here, multidisciplinary approach with urology surgeons, with plastic surgeons, as you saw that case with advanced cervical cancer. Our gynae oncologists run a pelvic exentration service as well, which is a nationally accredited service that we, as orthopedic surgeons, are part of. Now, when your patient has a tumor that is not resectable, I can't really comment on whether that particular tumor was resectable or not, because I don't have scans. But in Oxford, if a rhabdomyosarcoma was not excisable, surgery would only be indicated for palliation, obviously, and I think that's what your patient had, which was to ease the pressure on the bladder, maybe, and then you would have to follow it up with systemic treatment. I don't know if I've answered your question.
Thank you very much. I have got another question from Joseph, please, regarding the osteosarcomas. Okay. Patient having huge tumors of osteosarcoma and at the same time having secondaries in the lungs. Would you go for surgical removal and chemotherapy, or just chemotherapy, please?
I may have missed part of that question. So if an osteosarcoma patient with a large tumor.
So I think the question is that there's a large tumor, osteosarcoma, in addition to pulmonary metastasis. Yes. What would be your approach? Would you go for surgery or systemic chemo?
Yeah, we would initially treat those patients with chemotherapy, systemic chemotherapy initially, and we usually give 10 weeks of therapy with the idea that we hope to make the primary tumor more resectable, although oftentimes an osteosarcoma doesn't regress dramatically to chemotherapy, as you know. But we also want to keep in mind that there are micrometastases in addition to the radiologically evident metastases that we want to treat with chemotherapy. So we would treat those patients with standard MAP chemotherapy, just like we would with a localized osteosarcoma, and then usually approach primary tumor resection around week 10, and then we do staged thoracotomies to address the lung metastases, usually after cycles 3 and cycles 4.
Well, usually our patients, they come in very advanced stages, and the same thing with the soft tissue sarcoma, having secondaries in the lungs. Should one go for surgery to have a debulking opinion and less tumor burden for the chemotherapy or not?
No, it's a great question. We tend to think of the chemotherapy as being more effective in a minimal disease setting. That being said, we try to avoid debulking procedures in sarcomas in general. We don't think that they're generally advantageous. And so usually, again, in a patient with advanced disease, we would start with neoadjuvant chemotherapy, try to better control their tumor burden, and then pursue surgeries, and again, usually multiple surgeries depending on the sites of disease later on.
Okay, thank you.
Yep, of course.
Yes, Professor Pressy, it's nice listening to you always. We were listening to you last year, and this year it's always a pleasure. And the way you are unfolding all those mysteries of the sarcomas and research and targeting the treatment. So I wonder, as an orthopedic surgeon who's doing oncology most of the time, I wonder when we take out the tumor and we find out that the result is 10% necrosis, 20% necrosis. So then we know that in few months it's going to come back with the recurrence, and so it happens. So is there any way we can find it out earlier? I'm asking you this because we are 5th in population in the size in the world, but not by GDP. So after having done the prosthesis and the expensive surgery and everything, and in few months you have to do the amputation or something like that. So it's a bit of it's a tragedy. So if there's any way of finding out earlier before the surgery.
Yeah, no, I mean, I think that's a great question, and something we're battling here in the US as well, I think probably what we're looking for are biomarkers. And, are there better ways to determine response before you pursue, a heroic surgery potentially? I think PET scans are becoming more useful as a way of measuring response, and they do often correlate with tumor necrosis. So that's become more helpful. Although that being said, if you're just treating a patient with 10 weeks of chemotherapy, if you're doing a PET scan or some other biomarker assessment at week 5, sometimes that's not enough time to really determine how effective the chemotherapy has been at that point. So some of it is just having enough time to really make a good assessment. But I think as far as other biomarkers, we're really interested in circulating tumor DNA, cell-free DNA, as well as ways of measuring sort of liquid biopsies to assess tumor response. And so that's probably going to be the way forward and going to be our best sense of how well somebody is responding. And there's some early data out there, and I didn't go into that today, that really shows that that's probably going to be a really useful technology for us. So I'd say circulating tumor DNA, cell-free DNA is probably going to be our best biomarker moving forward to assess response before you get to the point of surgery and trying to assess tumor response by histology.
That's great. That's nice to know. Yeah.
I had a quick question for you, Dr. Pressy. So in our setting for relapsed osteosarcoma and Ewing sarcoma, we take into account the time from remission. So like if somebody is relapsing within a year, a metastatectomy cannot be performed, we are generally not offering systemic chemo because of the financial toxicity and the fact that they may need admissions. And so we basically, because of our resource limitation for an early relapse, which is not curable with surgery, we're just not even offering systemic chemo. But what is your experience with the time to relapse and the prognosis of that in osteo and Ewing sarcoma?
No, I mean, that's a fantastic point. And certainly within a year of ending therapy, the prognosis is very poor for a recurrence that's happened that quickly. Beyond 2 years, we think of as generally being very favorable. And our approach is similar to yours, is that we take a more aggressive approach with a late relapse than we would with an early relapse. I think when it comes to an osteosarcoma specifically, the question is usually lung metastases. We have had some success with early relapses when it's been oligometastases. So especially, say, less than 5 or 6 lung lesions, we will usually take a fairly aggressive surgical approach, even in an early relapse in that setting. And like you, we aren't that anxious to use chemotherapy in early osteosarcoma relapses, given the toxicity and the really lack of benefit. So it's usually a judgment call. Part of it is the motivations of the patient, and also just the resectability of the lesions that we see, and and the surgeon's willingness to operate. So I think there are a lot of factors that go into it. But yeah, I think that the time to recurrence is a very important prognostic factor and needs to be taken into consideration. As I showed earlier, the prospect for long-term disease control in this setting is quite limited. And so we certainly have a lot of challenges here still. I agree.
Thank you.
Thank you for that. Any other questions?
Is Dr. Athar still there? Dr. Athar?
Yep, I'm still here.
Yeah. Hi. Yeah, like I said, I'm working here at Shaukat Khanum, Lahore, orthopedic oncology surgery, and it's really amazing listening to you. A lot of discussion being going on these days on this PSI, patient-specific instrumentation, and the 3D printing, and you give us a good demonstration of that. And then there is discussion going on for the augmented reality, where you wearing the glasses and see everything and get positive margin, not to get the positive margins. So what do you suggest is the future of pelvic surgery? We have done a study, but it's in the form of a poster here. If you go to our website or the Symposium, you will see we've done about pelvic resection, about 20 plus odd cases, which we'll publish shortly, is in the form of poster, you will see. So I have to go next level. My question is, what do you recommend we should be looking forward to get? Is it a 3D printing thing, or the other one, augmented reality, or both? Whatever. What do you suggest, please?
Yeah, I think when I used to practice in Pakistan not so long ago, so I understand these socioeconomic sort of hurdles of trying to get expensive technology in the country. Navigation comes with a one-off expenditure, but it's quite difficult to learn and master. 3D printing is cheap because once you learn the production of jigs, it's not very expensive. It does not require very high quality printer. In fact, last year at ISOS, there was a presentation by an Indian surgeon from Chennai, I believe, and he is obviously manufacturing it. There are countries, and I'm sure Pakistan is one of those countries, where medical devices are not as strictly regulated as some of the Western countries, because here we have to go with the manufacturer who's got CE marking, who's got medical device grade materials being used. But in India, there were a couple of centers who were essentially manufacturing it locally at a fraction of the cost that it is in the UK. So I think for now, PSI would be a good thing to invest in Pakistan. And there are a number of people who have contacted me, for example, to advise on technology, including implant manufacturers in Pakistan. However, in the future, hopefully we'll move to augmented reality. And I will also take this opportunity to answer a question exactly on this on the chat, on the Zoom chat. So the answer to your question, and this from Shuib Asad, it does not use artificial intelligence. It uses human intelligence so far. There's no machine learning involved in PSI jigs. But does that answer your question, sir?
So what I understood is you do all this at your hospital. Inside the hospital, you have this system of doing the PSI and the printer, both. Is it so?
Yes, but it's not owned by the hospital. It's owned by a company. But the good thing for us is their office is based in our hospital.
Right. Okay, thank you.
There is a question from the online audience from Dr. Atar Siddiqui. He's asking about the use of artificial intelligence tools to further enhance these navigation system. Probably he's asking about the 3D printing and these things and the use of artificial intelligence in these.
Yeah, that's what I attempted to answer. I said, well, there's currently no machine learning or artificial intelligence involved in developing these models. It's all done manually in terms of planning. But once we have got augmented reality, I think those systems are ideal to introduce machine learning in terms of generating margins. In fact, our project also includes, because it will be navigation, so there will be live feedback on your planning intraoperatively. And that is when essentially, for example, the system will alert you when you've gone too close to the tumor. You'll still be wearing goggles, but if your saw benches too close, there will be an alert, and that will sort of, be your artificial intelligence model. It won't be as advanced as some of the other machine learning models.
Thank you very much. This concludes the session. I would say special thanks to our presenters and speakers. This is all from us. Thank you very much.
Thank you.
Thanks so much.